Hello everyone, welcome to Dr. Chan's Minor Ailments Forum. Today I would like to talk about a topic that we probably heard about it quite a lot in movies and TVs, but we don't really know much about it in general public. It's bipolar affective disorder. When you say this name, people think, someone who's got this condition will have split personality or have different kind of emotions swinging from one point to the other. Well, actually, this is not entirely correct. So I just want to use this opportunity to tell you a bit more about this disorder, because I find it fascinating because of the genetic component of it, and also the presentation is much more complex than people think. It's only either you're sad or you're feeling low. So another point that I would like to make is that the people who's got this condition, by statistic, they show that the attempted suicide rate is about 25 to 50%, with completed suicide in 10%. So it's important to get, good diagnosis of this condition and provide the appropriate care in order to protect these people and make sure that they're safe. So recently I went to a meeting in the RCGP headquarters, and I come across one of the literature that we produced from RCGP called Innovate. And this is actually a booklet for trainee doctors, trainees GP rather, and they give you information on different topics, like hot topics, to keep you up to date. And they have got a very extensive section on bipolar affective disorder. So I'm going to tell you some of the snippets from this article and just give you more information about this condition. So one interesting thing to learn about is that bipolar affective disorder, the cause is actually unknown, but however, it's got a very strong genetic link and also has a component of neurohormonal and psychosocial risk factors. Now, neurohormonals, which actually means the pathways and also the chemicals that we use in our brain, and one particular pathway that we're interested in this condition is the hypothalamic pituitary adrenal axis. Now, it sounds complicated, but if you actually crack down into the simple biology, it's much easier to understand. Now, hypothalamus is a structure in our brain. Okay, so cortisol is released in response to stress, and then our body will sense how much cortisol we have in the body and then feed back into the structure hypothalamus. And when the hypothalamus senses that you've got too much cortisol, then it will suppress further cortisol release. However, you can imagine that, let's say this feedback system is not working. So you've got too much cortisol in your system, but you can't feed that back to the hypothalamus to suppress that. That can have an impact on your mood. There's a theory also behind the thyroid axis, and they feel that if the thyroid hormone is not regulated properly, that can also play a part into bipolar affective disorder as well. Now, genetically, this is the interesting part, because they obviously there's been loads of studies done on bipolar affective disorder and see how their link, is there any genetic link in it, and basically they've studied on families. So they've shown that the risk of developing this condition in first degree relatives is actually 5 to 10 times greater when compared to general population. And that's a study that's done by Crandock and Jones in 1999, if you are interested in looking into further. However, they also looked at twin studies, and they show that there's a 40 to 70% increase in the risk of developing this disorder if you are identical twins. Now, apart from genetic, it's also been shown that psychosocial factor can affect the development of bipolar affective disorder, especially in places that are hostile, or people feel that they are socially isolated, and if they feel lack of support, and if you're already prone to developing bipolar disorder, then you're more likely getting that when compared to people in a more stable environment. So sometimes you don't actually need the genetic link to have bipolar disorder down the line. But most of the time, saying that the prevalence in this country at the moment is estimated to be around 0.3 to 1.5%, with generally the onset of age quite young, around 21 years old. So with bipolar affective disorder, you generally have two phases, but it's never clear cut, I would say. So it's not like, you suddenly feel really high for a few months and suddenly you crash and become very depressed. And you can have a mixture of it, as in the high and low can happen in very short space of time. Or maybe it's a transitional thing, like for example, you've been high and suddenly gradually you become low. And it's quite hard to spot, depends on when you're actually starting to see the patient. Also, it'll be difficult to assess the patient if they are at the high, because when they're at the high, they quite a lot of the time might lack the insight that they are in the high or having any problem, and they sometimes might have delusions or have different kind of ideas that they wouldn't normally have. So in order to make a proper diagnosis, number one, I would say you need a good collateral history. Maybe people that actually know the person saying, well, he's not normally like that. He's normally quite placid. But in the past few months, he's been, let's say, not sleeping at all, up all night, doing loads of things, starting a new business, or doing things that he would never do. So, things that are alarm bells would be very hyper and full of energy and don't need to rest, or become very brave and taking risk all the time that they never used to. So this phase we generally describe as manic or the hypomanic phase. So it's defined as permanent or persistent elation of mood and also increase in energy levels, as I mentioned earlier, for at least 1 week with at least 3 of the symptoms that I'm going to mention below. I'm not going to go through every single point, but I'm just going to mark a few key features of mania so we know what exactly we're talking about when we talk about someone is manic. For example, as mentioned earlier on, they will have elated mood, very active, easily excitable, sometimes irritable and aggressive, and they don't need to sleep, and their thought is all over the place, think about loads of things at the same time. They talk really fast, and they might not be so careful with the money anymore, or they can be socially inhabited at times. So they might be doing things that actually people think it's not okay to do in public, but they do. Another point that I need to make is you're not always manic. Sometimes you could be hypomanic, which is a slightly milder presentation of the manic phase. So when these patients are entering the depressive phase, they present very similarly to someone who's depressed, I would say. They would have no motivation to do anything. Things that they used to do, they don't do it anymore. Feeling tired, but doesn't matter how much they sleep, they're tired all the time. Concentration is poor. Sometimes might even thought about harming themselves or even not wanting to live. Now, we have to bear in mind that, depression comes with a spectrum. With all these things, a spectrum is important things to think about, because you're not always going to present with all the points that I talk about. They might be just entering the depressive phase, so you might only see 1 or 2 things, just saying, feeling tired and don't really feel like doing anything, to another spectrum of having every single point that I mentioned earlier on. We sometimes have patients coming in and said, I worry that I've got bipolar. Now, this is a condition that I wouldn't make a diagnosis easily, because I don't think a GP should make a diagnosis like that, because this is very specific, and you can have symptoms similar to bipolar disorder, but not until you've been seen by a psychiatrist. I don't think that a GP should make a decision on whether someone's got bipolar or not. We can suggest that, it sounds like it could be bipolar, but by making a diagnosis, it actually can cause serious sequelae for the patients. For example, it will become a label. So if we actually made a wrong diagnosis, then they might have to live with this label forever. And number one thing that we need to do is, if we recognized people who's got symptoms of feeling high and low at time, or bipolar-like symptoms, then we would promptly refer the patient to the psychiatric team for further assessment. And another thing that we shouldn't forget is, depression or high mood or changing of mood could be related to so many other things, which is not necessarily psychiatry related. For example, in previous shows I mentioned, let's say if your thyroid is playing up, you might feel low, you might even feel high, depends on whether you are low or high in thyroid hormones. And it's worth to think about, are there something else that can cause the change of mood, maybe in patients with dementia, or someone who has had a stroke and then maybe part of the brain's been damaged, then their personality and moods can change as well. And let's not forget, people who take recreational drugs or even drink alcohol, if they're under the influences of these medications or drugs, then they would potentially have a change of personality and behavior. So it's worth thinking about that as well. So let's say someone comes into the surgery and present with similar symptoms to bipolar affective disorder. What would we normally do? And I think number one thing that we need to do is to assess their risk, the risk to themselves and also risk to other. Obviously, the risk of suicide is need to be assessed, but you shouldn't actually just concentrate on that kind of thing, because risk can also be, let's say, if they're self-neglecting, then they won't be eating. That would be a harm as well. I think either way, if we're suspecting someone who's got bipolar affective disorder, we would generally refer, but the urgency of referrals depending on the risks. I would say that out of like a GP setting, let's say somebody has never been diagnosed with this condition but presenting in that way, and the family or friends feel that he's at risk to himself or to others, and let's say the GP practice is not open because it's weekend, then the most important thing is to either take the patients to A&E if they're at risk, or to even call the police if you feel that they are at risk of violence or aggression. So generally, treatment-wise, for bipolar affective disorder, the medication will be under the branch of mood stabilizers. I must say that's not one medication that will be better than others under the branch of mood stabilizers, but I must say that lithium is quite a lot of the time being used for this kind of condition. And this is not a new medication, and has been trialed for a long time and is proven to be effective. However, one downside about this medication is that the toxic window is quite slim. So what it means is if you take in a little bit more, and if the toxic window is narrow, then it means that it's very likely or easily you can get, overdose yourself and have a first effect. So most of the time, people who are on this medication will have regular blood tests to check the lithium level. Sometimes in patient who has regular relapses, maybe one medication is not enough, so you might want to consider adding 2 or 3 medication on top to prevent the relapses. And I must say that recently, when I say recently, I'm talking about the past 10 to 15 years, that there's a new medication that's been out called lamotrigine, which has been used quite widely in the community now from the advice from the psychiatrist for treatment of bipolar affective disorder, which is quite good because of the specific side effect profile. Apart from medication, there are other treatments for this condition as well, and the most commonly used for patient who is more or less stable but in the community would be a cognitive behavioral therapy, which study has shown that if the patient is compliant to this treatment and actually wanting to be better, CBT is very effective for quite a lot of psychiatric disorders. Now, I would say that patients with bipolar disorder diagnosed need to be reviewed by the GP and also by the psychiatric team on a regular basis until they're in remission. We're not just thinking of, reviewing the mental health side of things, but also need to look into their weight and also check blood pressure and making sure that they're physically well, because some of the medication, as I said, need close monitoring, and some of the medications can actually cause weight gain or leading to secondary, let's say, high blood pressure or high cholesterol, etc. So it's important for the patient to have at least once a year appointment with the GP to have blood tests and also to discuss how the medications are working for them. So I think the take-home message regarding bipolar affective disorder is that it is relatively uncommon in the society. However, we need to ensure that we make proper diagnosis for these patients in order to support them in the community and also to keep them safe. I think the most important thing is that if you suspect or know someone who has got similar symptoms to bipolar affective disorder, or even just depressed or acting out of the characters, it's worth them to go and see the GP to have an assessment, at least do some blood tests to make sure that this is not something organic that we can treat without seeing a psychiatrist. And if we suspect that the patient who's got this condition, we will refer the patient promptly to the psychiatrist for review. So I hope that this topic is something different and something that you don't hear much in the media, for example, the TV or radio before. And take good care of yourself until we meet next time. Bye-bye.